Thanks very much for a fantastic lecture and outlining, I guess, the future, what lies ahead with exome sequencing in cardiac anomalies. So we're going to move to a live scan. And we've got two patients lined up, one a late first trimester and the second patient, late first trimester and the second patient a second trimester scan. So in starting in any examination, I start off with a sweep coming down to the urinary bladder. This is the cervical canal, the cervix. Then I come up to the urinary bladder. For every examination in the first trimester, patients take 2 glasses of water 20 minutes before the examination, and we start with a transabdominal examination, then proceed to transvaginal. So in a sweep, as I do from cervix to fundus, I establish that the baby's lying in breech presentation. Not that that is relevant in the first trimester, but more for me to understand position, size, axis, and situs. And the head is up at the fundus of the uterus. I then go in a longitudinal section. I then go from sweeping from the cervix over to the left pelvic side wall and to the right pelvic side wall, confirming that there is one single baby on board. And then I come around to look to see that there's heart motion. So that's just a broad introduction to check a single live fetus. I then bring my probe around to the examination to make the spine in a 6 o'clock position. The next step in doing that is you'll see I'm running at a hertz around 29 hertz. What I do next is I reduce my sector width, and that goes up to 57 hertz. I might just have a little bit more gel. Just hold on for a second. Just drying up on gel. So then I've got the sector width down at 57 centimeters a second. Once I'm down at 57 centimeters a second, I then reduce my depth. And then the next after reducing my depth is to HD zoom. I then increase my dynamic contrast, and then I use a slight total zoom. One very important thing in any first trimester imaging is to have a high degree of magnification. And I split my image showing that my stomach and my sweep, because I know the baby's breech, the stomach is on the left-hand side, and then I sweep up to showing the 4-chamber view of the heart. In any examination, I look at the size, the axis, the rate, the rhythm, and the position of the baby. SARP. And as I look at that, I see that the size, the axis, the rate, and the rhythm looks normal. I can appreciate that 2/3 of the baby's heart is in the left hemithorax, and 1/3 of the baby's heart is in the right hemithorax. So that's 2/3, and this one here is 1/3. So as I come back to the ISUOG guidelines, I then sweep, say, looking at the intrahepatic vein as it comes in and sweeps away from the stomach. This is the stomach here. The descending aorta is to the left, the spine, and the IVC is anterior and to the right. So all the landmarks are, and I'll come back to these in color to show the position of the aorta and IVC and intrahepatic vein. On the 4-chamber view of heart, I then just go into the heart itself, not just the thorax, but I just want to image the heart. I slightly increase my dynamic range. And the chamber, this is the descending aorta. The chamber close to that is the left atrium, left ventricle, right atrium. And this is the foramen ovale, which is a hypermobile foramen ovale at 16 weeks. So that's my 2D evaluation. I now move to a cardiac preset because this is going to be better for color. When starting off with a color Doppler evaluation, I will start off with color with a PRF, which I've set at 23 centimeters a second. So remember the order I spoke about, start off with a PRF, and I'm going to slightly increase my PRF to that just to get a cleaner image showing the left ventricular outflow tract. Very quickly, because I don't want to lose it, this a part of a first trimester screening, and I'll talk about this tomorrow, is to get a 3-vessel tracheal view and a 4-chamber view and save that image to file. So if I come back to the 4-chamber view of a heart, I'm looking at the flow across both left and right side. I split my image, and at the same time, I'm looking at the movement of my mitral valve and the movement of my tricuspid valve. After using that as a color, as a preset, I said to you that I have a general preference for power in the first trimester of pregnancy. So I'll go back to showing the 4-chamber view in this baby, and next thing I'll move to power. As soon as I've done that, you see the arm has moved over the chest. So I'm going to change my angle to get the fill of the ventricles to come around the arm. You will see also that in my box size, that I will choose the box that just colors the cover over the ventricles. And then I magnify the image, and I'm not getting enough fill of my ventricles. And I know that because if I split my screen to 2D, I can compare what I'm seeing on the left and the right side. So my PRF, when I look on that, is actually at 24 centimeters a second. I'm now going to increase my acoustic output. But if you look in the top right-hand corner, I've just gone over a thermal mechanical index. So I need to pull back on that because I want to try and keep that at 1. And then the last control that I touch is my color control. And then once I increase my color control, then I'll get better fill of the ventricles. I'm going to slightly increase as well. I'm going to increase the 2D. So as I'm looking at that inflow into the ventricles, I go back to a single screen. I can't see any evidence of tricuspid valve regurgitation. I rotate my transducer to get the left ventricular outflow tract. As I do that, I go back to my split screen because this allows me to visualize the movement of the aortic valve at the same time as seeing the color flow across the aortic valve. As I do so, I see the aortic valve disappears during ventricular systole. Can see the caliber of the aorta is appropriate, and there's the continuity of the anterior wall of the aorta with the interventricular septum. So I've moved up from a stomach to a four-chamber to a left ventricular outflow tract, and the first thing you see from moving four-chamber going up to the three-vessel tracheal view is the left ventricular outflow tract. And then I go back to my four-chamber view on a single screen, just reduce my magnification, and I'm now going to sweep from a right ventricle up to showing the right ventricular outflow tract. I'm going to slightly increase my color gain. And as I do so, I then look for the main pulmonary artery coming out of the right ventricle. This is a first trimester scan, and seeing the pulmonary valve is not as important as it is at the third trimester because it tends to be an evolving cardiac lesion during pregnancy. It's uncommon to make a diagnosis of isolated pulmonary stenosis the first trimester. We do make it with tetralogy of Fallot, and I will talk about that later this morning. What's important is when I come up to this view here, I see the three-vessel tracheal view. This is the trachea. The vessel closest to the trachea is the transverse aortic arch. Therefore, this is the arterial duct, and this is the pulmonary artery. Remember, red is up, blue is down, your PRF is set, your power output is less than 1, and your gain gives you visualization of both of these vessels. And there is laminar flow through the pulmonary artery, the arterial duct, and the transverse aorta. To moving from power, so I've gone from color to power, and that's in a screening context. If I'm doing a fetal echo and I want more detail, I come back, I start off with the chest because I want to see the pulmonary veins now is doing a more detailed assessment first trimester. This is a beautiful baby, en corazón muy bonita. Esta es la venas pulmonares, esta auricular a la derecha, auricular a la izquierda. No, lo otro, esto. And then you see the pulmonary veins entering on 2D. Okay, so next we move to slow flow. And I was talking about slow flow, and let me walk you through the controls in slow flow. So the first is I press slow flow, and then I select radiant max on slow flow. I then go into, with slow flow, a split screen, and that's a monochromatic map, but I'm just going to give you some directional information first. And what I have on the left-hand side is the 2D, and what I have on the right-hand side is on color. And now you can see las venas pulmonares aquí, a la izquierda, y eso a derecha. ¿Es correcto? Yes, correcto, de acuerdo. Yes. And here you can see the interventricular septum and the fill of the ventricles. And as I sweep up from this four-chamber, then up to the three-vessel, you can see I'm getting the branch pulmonary arteries as it exits out of the right ventricle and then continues superiorly the arterial duct. And as I do so, I then move up to looking at the subclavians. And I made the point when looking at the subclavians that this is a position that you may need to bring the baby around into a different position. I'm going to come out of that for a second, submenu, and I'm going to go to a single screen display. And I'm now just going to come around to see if I can bring the subclavian arteries into view. So as I come around, I'm now up to the clavicles. And on this position, then I look at actually, by the way, as I come across this, if I can just ask you to have a look, you're not just seeing the pulmonary arteries, you're seeing the tiny little branches of the pulmonary arteries as they disappear out into the lung parenchyma. And you can also see coming up in here, the superior vena cava. Actually, I'll come around to this position. You can see in the superior vena cava draining into it as we have the azygos vein. So the trachea, transverse arch, pulmonary artery, and then this here is the azygos vein coming in to drain. And I'll just slightly increase, as I come out of that, slightly increase the gain, and now I need to reduce my box. So I'm just honing in on the azygos vein. This becomes important when I talk tomorrow about systemic venous anomalies. And if I just crank up the gain, then I'll see the azygos vein draining into the SVC. And as I do so, I also am seeing the internal thoracic artery or internal mammary artery. This is the left brachiocephalic vein, and this is the internal mammary artery on the other side. And in this view as well, it's a nice position in a sense of visualizing the systemic venous anatomy. So if I come out and magnify my image and then get a magnified view of where the cord inserts into the abdominal wall and then put on my slow flow, it allows me to see the confluence of the ductus venosus, the inferior vena cava, and the left hepatic vein. So the baby's a little bit active at the moment. And I've only, if you look once I'm in slow flow technology, I have no PRF control. So the only things that I control in PRF, in slow flow, is either power output or gain. And I can choose both of those. You will see straight away I pressed freeze. And this is where I use my cine loop, because I saw in a glance that I was catching the point of the infradiaphragmatic vestibulum. So this is the point where the inferior vena cava comes up and joins the ductus venosus, the right hepatic vein, and this is the infradiaphragmatic vestibulum, which then drains into the fetal right atrium. But I show you this in a sense because it's the detail that you get with these tiny vessels with this technology, and it becomes increasingly important very early in the pregnancy, which I will talk about tomorrow. Because not only are you seeing these vessels, you're actually seeing the vertebral arteries which are coming off the descending aorta, all the tiny, tiny little vertebral arteries. But here you have the cord inserting into the abdominal wall, draining down into the ductus venosus, hepatic veins, and then on into the right atrium. Coming back to the screening context side of things, if we go back, the heart, the apex is now in a better position. So in that position, I'm going to go back to taking slow flow off, and I'm going back to using color. As I do that, you will see for every image that I'm taking that they are very magnified images demonstrating flow in the heart. I go back to my starting principle every time I do anything looking at any vessel. As I go to my PRF first, I then go to my output, and then I go to my gain, the order of those three things. And then I sweep up to the three-vessel tracheal view, demonstrating those arteries. I don't know if there's any questions that anybody wants to ask from the audience about as I go along here, but as you look at this is the trachea and I head down, you can see the trachea then branching into right and left main bronchus. So if you look on here, this is the right main bronchus here, and this is the left main bronchus. If I come back, you can see it there. And you can see the cartilage of the bronchus on here side and on this side here. There is another nice control in any of these, is speckle reduction and compound imaging for seeing these tiny little vessels which you can use. But it tells you exactly the point where you are. This is the trachea, then you're down to right and left main bronchus. Here you have the transverse arch, vessel close to the trachea, transverse arch, pulmonary artery. When I'm looking in the first trimester of pregnancy, I'm looking to see that there's symmetry of the ventricles. I'm looking to see if there's normal movement across the valves, just to make sure there's no tricuspid valve regurgitation. For those of you who are interested in stick, I'll just do a quick run through on stick, but this is the RM7C, which is a 3D probe. I select RM7C and I select first trimester. So if I just come out of that, and then find the baby's heart, and once I have the heart in view, I'm just going to increase my gain. Then I'm going to HD zoom and just magnify. And the stick I'm going to do will include the thorax just as a screening stick. As I'm pressing here, I'm maybe just pressing too hard on the abdomen, I'm squashing. Thank you. And now I put on my color. Once I'm on my color, I'm going to increase my acoustic output. And then I'm going to select 4D. And when you're doing a stick volume, you start at the top and work down. So I'm on first trimester. My acquisition time is 15 seconds. Because it's a small heart in the first trimester, 25 is perfectly adequate. Then I ask, before I do anything, I then sweep up to the 3-vessel tracheal view and check my position, then move my box up, and then I ask him, no respira, por favor. And then I sweep, going from a 4-chamber up to the 3-vessel tracheal view, and I catch the ventricles and sweeping up to see the right ventricular outflow tract, sweeping up to cross the transverse arch. And you can see I fell just very slightly short. When I select that A plane, I very quickly go to the A plane, I translate to get my 4-chamber view, and then I press this button called stick, VCI, and that gives me a nice fill. And then I slow down the speed, and then I use this volume speckle reduction imaging, and I set that to a setting of 5. And as I do so, I then can very quickly demonstrate a sweep going up from the left ventricular outflow tract to the aorta coming out the left ventricle, and then up to the 3-vessel tracheal view. And I was just missed out on the 3-vessel tracheal view, and I saved that to file. And we'll be seeing many examples of the power of stick during pregnancy over the next 2 days. But that's just an instructional outline of how to do a stick evaluation. And I will do one more, and this time I'm going to increase my angle to 30 and just do another sweep and just check up before I acquire, check my positioning is okay. Otra vez, no respira, por favor. So, 5, 4, 3, 2, 1, and respiro otra vez. Okay, so then we have accept, and we have a better volume, I think, on this time. When you use a thing called wide slice VCI, I'll slow the speed down to 50%. Now, wide slice VCI allows you to produce a 3-dimensional image very quickly. I'm on a 1 millimeter thickness. If I select to go up a thickness of up to 20 millimeters, you can see straight away it produces a 3-dimensional picture of the baby's heart. And that's a nice thing to do in terms of looking at structural anomalies in the first trimester, rather than going to a multiplanar and then jumping to the rendered image. And the rendered image is always a sort of a nice image in terms of looking at of abnormalities. But this, in a sense, a lot of the time is for teaching purposes, but also in some diagnostic setting. I don't want to spend too long on that, but I saved that volume to file. There is another patient. Will we jump the next patient on the couch if we have time? How long do I have left, Fatima?
No, let me 20 minutes. 12.
We jump to a quick second trimester?
If you want,
okay.
yes.
Okay.
In the meantime, is there any question or comment? Yeah, and in the app, yeah. Yeah, Simon, I might say you that it has been impressive how fast have you been able to get these super nice images. And I think that it's very important to get used to try to improve the settings always. Yeah, because I think you do it without thinking about it, but it's important. We have seen that you, without thinking really on it, you are, every time you acquire and then you magnify, improve settings, everything, and then you continue and you keep on improving the settings all the time. Yeah, because sometimes when I see that when people is trying to do the cardiac, when they see the baby in a good position for the heart, they go for it and they try to get everything even without really doing a good magnification or, yeah, because they don't want to lose that spot. But I think it's important to keep on training us to spend time on improving the image because it's really worth and it's really important to do that. And I think that when you are used to that, to lose time improving the settings, then you get so used to it that you do it super fast, and at the end you don't lose that much time. I don't know if there is any question from the floor. If you want to raise your hand.
Okay, well, I might just go straight to our next patient then, Fatima. So I'm going to start this examination with the RM7C, which is a 3D probe. On the second trimester OB setting, I'm going to go straight to that. So I'm not going to do my general overview as I've demonstrated a little bit earlier. So in this baby, I'm going to come down looking at the urinary bladder, which is quite empty actually. Then come up to the fundus of the uterus. So this baby is also in breech. And I open my sector width as I do a sweep from left to right hand side. So in doing that single sweep, I see there's a single live baby on board presenting in breech presentation. So I'm going to go through this reasonably quickly. So I'm going to start off by the first ISUOG section. I omitted in my previous talk about coming back. I said I'd come back to the first section, but this is where you're looking at the intrahepatic vein. So in the first section, the intrahepatic vein curves away from the stomach. Now you can see straight away that I'm getting no fill. Now, does anybody know why I'm getting no fill? The answer is because my PRF is set at 30 centimeters a second. So depending what I'm looking at will determine what I set my PRF. Now I bring my PRF down to 8 centimeters a second. Then I look at my acoustic output. My acoustic output is 0.9 from mechanical. I can afford to increase my acoustic output, and I'm increasing that. I'm up to now 0.9, 0.6. And only then after doing that, then I actually increase my gain. Once I've done that, I take my main menu and I split. So I'm demonstrating both color and 2D. I've confirmed already that the stomach is on the left-hand side, and I can see that the intrahepatic vein comes in, curves away from the stomach, and the fetal gallbladder is on the opposite side. And I'll show you examples of this tomorrow where it becomes abnormal. When you're looking at the first section of the baby, I'm going to go back now after split screen. I'm just going to go back to a single screen display. I'm going to magnify, and you see through all this cardiac imaging is that I've got a very high degree of magnification. When I'm looking at the aorta and the IVC, you want to confirm that the aorta is on the left-hand side of the spine, on the same side as the stomach. When you're having difficulty in visualizing the intrahepatic vein, which does happen quite often, this is where my friend slow flow comes in, because you press on the slow flow, your slow flow will demonstrate the vessel and the branching of the vessel as it comes in, and you can see the ductus venosus. You will see, by the way, when I'm imaging, there's like a background. I did not mention this earlier, but there is the option to turn your background off to show your vessel. The only time I'd ever do that would be in a split screen. And this allows me to watch and track the ductus venosus as it enters into the infradiaphragmatic vestibulum, and just a very quick way of bringing that into view. But again, slow flow is just a nice way when you're struggling with conventional Doppler of seeing vessels, turn it on, and it's an extremely powerful tool in the first trimester of pregnancy. We then move up to the next section, which is examining the baby's heart. So in this heart, first thing I'm going to do, go back to my cardiac preset. I'm going to reduce my sector width. My next is I'm going to just take the heart, because I've done size, axis, rate, rhythm, and situs. And as I'm looking at the heart, I see that the heart, 2/3 of the heart is in the left hemithorax and 1/3 of the heart in the right hemithorax. I see there's some free fluid around the right pericardial space. Again, just to show you the power of this technology, it doesn't show up on Doppler, but it does show up in slow flow. And as I split my image, I then reduce my balance. And as I crank that image up, I can then now see my balance. There are times where we are faced with, in obstetric imaging, seeing what we think is pericardial fluid, but in fact, it's not pericardial fluid. It's actually sometimes myocardium can mimic a pericardial effusion. Very quickly, slow flow will give you an answer whether that's muscle or whether that's fluid within the pericardial space. So just to come back to the four-chamber view of the heart, we magnify the four-chamber view of the heart. The chamber that's closest to the descending aorta is the left atrium, left ventricle, right atrium. As I'm looking at that four-chamber, I want to optimize my image. So I'm going to come out of that. There is an option here to go to radiant, and radiant gives me edges to the AV valves. So if I see it, I get a better demonstration of the AV valves, and I can see that there is the normal offset. In visualizing the AV valves, I do this with the apex pointing up towards 12 o'clock. This is where I believe that you will best understand offset. It also allows me to see the moderator band that's present inside the right cardiac ventricle. I rotate my transducer from that to the left ventricular outflow tract. I then come down again for all the way through every cardiac imaging. You will see that I magnify the structure that I'm looking at. You can see the slight dilatation after the aortic valve. This is where the valves nest after they open, and that's completely normal. It's important to see the continuity of the interventricular septum with the anterior wall with the aorta. When I'm putting on my color Doppler in this setting, I then, first of all, look at my PRF. How many weeks are we, gestation? 20. We're 20 weeks. So we're 20 semanas. So the PRF is at 34. So I'll need to increase that. And I'm going to go up to a PRF of 54 centimeters a second. And you see that there's not enough fill of that vessel. So my next thing is I look in the top right-hand corner and I see my output is I can afford to increase it. So I'm now increasing my output. And then my last control then is to increase my gain. Once I have all those settings, I can then compare a 2D and color side by side. I can also change my radiant to max. And this is how Reem produced those beautiful images, which he demonstrated, is by using those controls, exactly what I've just described. For a mid-trimester examination, I would choose color, and this preference over the power and slow flow for a routine screening context. If there's any valvular abnormality, I will use the cine loop and very slowly watch the AV valve here, whether it opens and closes in the setting of where you've got valvular abnormalities, aortic stenosis, pulmonary stenosis, Epstein's, and so on. It's then that power of cine loop and just watching each tiny single movement. But also it gives you an understanding that your settings are right. These are correct settings using those three things which I mentioned about in my golden rules. If I come back to the four-chamber view of heart, when we were talking about looking at the right ventricular outflow tract and the free wall, is I go to the four-chamber, and all I do is I just angle my transducer up cephalad. And as I do that, I now have the free wall of the right ventricle in view. I have the pulmonary valve in view. I have the aorta in view, and I have the SVC in view. I'm happy with that in terms of excluding pulmonary stenosis. And I go through the exact same exercises. The same preset is held over from my left ventricular outflow tract examination. And then again, importance of magnifying the image, splitting it, and then narrowing it down so you're just over the vessel that you are interested in. And then you can tweak your settings of PRF gain and power output. But looking at that, I can see that there's a normal pulmonary valve that appears and disappears during ventricular systole. And then I come up to see my aorta. The pulmonary artery should be larger than the aorta, which should be larger than the SVC. If I come down on that, onto the four chambers, back onto the four chambers, it's important to look at the coronary sinus. So if you look at the tram tracks coming across here, you look to see what the size of that. That should be less than 3 millimeters as a useful landmark. If you feel that the coronary sinus is prominent, look beside the pulmonary artery. There should never be a vessel beside the pulmonary artery, and that's the clue of either a persistent left SVC or an ascending vein of a total anomalous pulmonary venous return. Sometimes you can catch the atrial appendage on the left-hand side that can mimic the appearance of an extra vessel, and to prove that it's not, just go a little bit higher to get it out of view. Back to the fourth chamber, you should see the moderator band should be present inside the right cardiac ventricle. Descending aorta, left atrium, left ventricle, right atrium. As we look at around the pericardial space, we look to see if there's any fluid around the pericardial space. I'm on a setting of Ultra HD. which would show to me if there was anything there. I saw some fluid around the right pericardial space. This is a normal variant. And the most common place where you see pericardial fluid, like this small amount of pericardial fluid, is always the right ventricle. When you see fluid in the pericardial space, you always ask yourself the question, is the fluid extending up to the level of the AV valve? And the second question you ask is the fluid circumferential? As you're looking at the four-chamber view of heart, you always ask when there is ventricular discordance. You can see that the right cardiac ventricle is larger than the left. This is a normal finding, especially in the third trimester. The right ventricle is larger than the left. But always ask yourself the question is what forms the apex of the heart? And you can see that the apex of the heart is formed by the left cardiac ventricle. An important observation, more to make in the setting when there's ventricular discordance. As I'm looking at the pulmonary veins entering into the four-chamber view of the heart, I go up to the left atrium, and as I do so, I then go back to my friend's slow flow. The balance is held over from the last examination, so I have to bring my balance back up to 225, and then I go into a split menu. So I go into a 2D and a 2DC, and then I look in the region of my left atrium to see and you can see them there, the pulmonary veins. You don't really need slow flow because it's actually seeing there in 2D, but it is showing me on slow flow here that the veins are coming in. If you are ever in a position where you want to show the inferior vena cava, the first thing is bring up a four-chamber view of the heart, go to the descending aorta, which defines the left atrium, or tells you that this is the left atrium. And then once you've got the right atrium, then just simply rotate on the right atrium. And once you rotate on keeping the right atrium into view, you will then bring in your superior and inferior vena cava. And this is what's called the bull's horns. So this is the superior vena cava coming down and draining into the right atrium. And then you catch the inferior. I'm going to rotate the transducer the opposite way, sorry. Just go back and do that again. So you find the right atrium and you rotate on the right atrium, and then that will bring your SVC and IVC, referred to as the bull's horn. So this is the superior vena cava coming in there. This is your eustachian valve at this point, which channels blood to go across. And this is your inferior vena cava, referred to la cabeza de toro. And there you can see them coming in there.
Simon, we have a question that they ask us, how can we see the four pulmonary veins, not just not only the inferior ones, but also the superior ones?
Yeah, in a 2D imaging, that's extremely difficult. The only person in the world who can do that is Reem Abu Rustam, who showed a beautiful example in her picture of the pulmonary veins. And she made the point was that you have to choose a slightly oblique view. In terms of bringing all four, it's very, very difficult on standard imaging. So I think for me, I guess it would be doing a stick evaluation. But let me try, Fatima. I'll do my best.
Yeah.
But the answer is it's extremely difficult on 2D imaging, full stop. It's more that we say in routine screening in the ISUOG guidelines, if you see if you see one pulmonary vein coming in, you've excluded total anomalous.
Yes.
The problem is on 2D, if you see a pulmonary vein coming in here, then you have to move slightly inferiorly to try and catch the other pulmonary vein, or superiorly, and it's very, very difficult to do that. So if I'm facing a scenario where it becomes important to do so, I'm going to take off slow flow. I'm going to go into a power Doppler setting, and the first thing that I do is my PRF, which is at 30, I'm going to bring that down. So I'm on a PRF of now 11 centimeters a second. I then focus on the left atrium, and then after my PRF down to 11, then I'm going to increase my acoustic output, and you see I've gone up to 0.8. Then in that position, I look to see, can I get my pulmonary veins in view before I acquire my 2D? And now I have I'm not really getting the fill that I want here. I'm going to try and change the angle. Maybe I should hand the probe over to Reem and get her to do this for me. So then we come down to the left atrium, and I'm not really getting the fill. But to answer your question, what would I do? Let me come around the corner. I'll reduce my PRF further, and then I'll do an acquisition on stick. So I'm down to 9 centimeters. Now I'm beginning to see the pulmonary veins just coming in here. So once I'm in that position, I see left and right pulmonary veins here. and here. And then I go into a 4D stick volume analysis. I'll select an acquisition time of 15 seconds, and then I do an angle. I only need a small angle. And then I'm going to ask the patient to stop breathing for a second. 5, 4, 3, 2, 1. Breathe away normally. So then I come across and I accept that, and I go to the A plane. So when you do any stick volume, it comes up with the ABC planes, axis, sagittal, coronal, and then the rendered image. So I'm just going to select the A plane. And once I'm in the A plane, my next button that I will hit will be VCI. Hang on, get rid of multiplanar. Multiplanar, A plane. And then I turn it around the Z axis, is the next step. And then I do a Y and X axis rotation with VCI. And then there's too much color here, so I go into a menu of where I increase my power threshold to try and write out some echoes. And then it's on the X-axis rotation that you try and catch all 4 pulmonary veins entering in. And I haven't got it there, but that's the exercise in which you go through. Yeah, you can see I've got 1 pulmonary vein on each side, but to catch them, that's the exercise. Do a acquisition, A plane, and X-axis rotation to catch all pulmonary veins. Because in 2D and color, it's extremely difficult. So I hope that answers that question.
In any case, I think you explained it very well, no? That in the clinical setting, what is very, very important in prenatal life is to not miss a total anomaly, no? That then, if at least we see 2 veins, of course, it's not perfect, but at least we are not missing this total anomaly that would be a neonatal emergency. And it's true that sometimes when there is an anomaly in the returnos venous, there is a collector or something weird that we can suspect. And then, as you were trying to show, no, that if we suspect it and we really want to see the 4 pulmonary veins in 2D, will be very difficult. So then we would go for the stick, as you were showing very nicely. Great. We are missing 2 minutes.
We have 2 minutes.
Yeah, 2 minutes.
Okay.
Because
I'll show maybe the ductus venosus, because in clinical practice, maternal-fetal medicine people will frequently, when doing ductus venosus assessment, we'll do it on an axial section, and they'll turn on color and they look for aliasing. It's not my preference. I think for every gestation, I think from an anatomical perspective, I'm actually just going to go back to my original preset. I think it's important to make sure that you're actually sampling the right vein, because I think frequently in clinical practice, we end up not actually sampling the ductus venosus. So I think the best way to do it is if you just come across, practically speaking, if I ever want to see the ductal and aortic arches, and I actually haven't spoken about those, is if I want to get to a ductal and aortic arch, and it's a sort of a golden rule really, is I start off by showing a picture of the stomach, and I get the rib on this side and I get the rib on both sides, so I don't end up with having an oblique section to the ribs. I get a perfect section showing clean ribs and stomach in view. If I can't get that, it's a staircase maneuver. Move the probe angle up or move the probe up and angle down. And when I've got a complete rib in view, I then flip my transducer 90 degrees. When I flip my transducer 90 degrees, it brings in my aortic and ductal arch. It's a very reproducible and quick way of doing so. But it's also in this view that allows me to see the ductus venosus. So 4-chamber, 2 complete ribs, and a perfect axial view, rotate the transducer 90 degrees, and then go to your power Doppler. And then once you're in your power Doppler setting, then I know that that's the ductus venosus just to that point there. If you want precision on your ductus venosus, you then magnify that image, and then I will use my friend balance, and I'll reduce my balance if I want to see the clarity of the ductus venosus. I may need to increase my gain, and then I can see the ductus venosus entering into the right atrium. So the other thing which you can do is, on this, just let me come out of it, go back to my presets. Sometimes when you get completely lost, you've pressed so many buttons and you want to get it out, it's better not to reverse. is just simply, ¿está bien? Is you just go back to the beginning. So once we're on that setting there, I want to just show you how to do it in the setting of an interrupted IVC. So, and ductus venosus anomalies. I'll select 4D, I'll go to an acquisition of 15, and I only need to do it 30 degrees across. And just let me, before I acquire, just let me see, do I have my IVC? We do, yeah. Okay, just stop breathing. 5, 4, 3, 2, 1. Gracias. Important when doing a stick volume analysis that you let the patient know how long they need to hold their breath for. And that's why for any stick acquisition that I'll always ask the patient, always let the patient hear me count down. Also remember, when you are in a position where you acquire a volume, it's very, very easy to start manipulating the volume and losing everything. So make sure to press P3 and save your preset. The next is again, I will go straight to my A plane. I'll magnify my A plane. And remember, when you've done an acquisition on a stick, hit VCI. It's just a beautiful button. And then use wide slice. And on a wide slice, it straight away gives a three-dimensional perspective. And then I slow down the speed. I don't have to do a rendered image. It allows me to see the course of the intrahepatic vein. There's no umbilical vein varix. It tracks normally, feeds into the portal sinus, into the left and right portal vein, continues superiorly as the ductus venosus, joins the left hepatic vein and the IVC, forms the infradiaphragmatic vestibulum, and enters into the right atrium. You have the aortic arch giving off the neck branches and the ductal arch here. You have the pulmonary veins. Oh, there you go. Right and left pulmonary vein on one side entering in, and then you have your descending aorta. It's just so quick to do that. If you are a render person and you've got a lot of time, spare time in your hands, you can go back to your multiplanar, hit the rendered image, go to full screen, and then just open up your region of interest, which is this button here. And then go into this mode here, which is a nice mode, Cineloop, press record. And then you can change on that. You can do some nice maneuverings. So select a grayscale background, and then go back to the main menu, and then use a gray silhouette. And this can produce a pretty nice image. And then along that, you can alter your light source in the bottom left-hand corner. But you know, these are things which we do, in a sense, only in the event if I was faced with an abnormality. I'd never do anything like that in a routine screening context. I might stop there. Muchas gracias.
Super. Thank you, Simon.
You okay?
Great.
Yeah.
So that was an amazing demonstration. Thank you very much to Simon and to the patients. And yeah, now we will move to the coffee break, and we come back at 11.